viewing and for the future people viewing, I'm Charlotte Marquis. I'm the practice anesthesiologist, and I'm going to start to do an education series about a variety of anesthesia and sedation topics. And the idea is that I want you to have as much information as possible so you can make the most informed, safe decisions for animals. So, the pre-anesthetic assessment. So I do assessments or physical exams on every animal that I either sedate or anesthetize. And I do this for a couple of reasons, and I think you should too. So what are some reasons that we should perform pre-anesthetic assessments on dogs, cats, and other animals? The first one, you care, right? So you want to make sure that you're giving the patient the best care possible, and that's going to start by performing a detailed physical exam and also getting a good idea of that animal's history. Because if you have an idea of what's going on, you're going to be better prepared for any kind of complications that happen. So we care. We want to be efficient. It never helps to be that person who walks into a room and says, no, I have no idea what's going on with this animal or what the problem is. If you're doing a procedure on a patient, you should be prepared to tell us about the history, the medications, any kind of weird personality problems that animal has, because that's going to make it seem like you looked through it and at least you're ready for that. So it's going to make us more efficient. It's going to reduce the amount of mistakes we make. So, quite a lot of you have probably done Recover CPR training before, and one of the cool things that we do during Recover training is that we cross-check each other and we fact-check each other. It's not necessarily about who has the best idea or who is the most correct, but it's really important just to review things with our teammates and make sure that we covered all of our bases, because especially when we're busy, when we're tired, when we're dealing with some type of emergent situation, you want to be able to say, hey, I actually noticed this and I think it's going to make our plan different. And that's really important, because maybe in the healthy patients that doesn't matter so much, but in the sick patients that can mean the difference between life and death. So pre-anesthetic assessment is also going to reduce the amount of mistakes you make, and it's also going to make you more of an effective team member. So, kind of like I said with fact-checking each other, kind of like Recover CPR training, if everyone knows the history about the animal and we are all on the same page, that is going to save us a lot of time, okay? And the other thing is, like I said, when you're tired, when we're working long hours, when the patient is critically ill, don't burden your teammates, your assistants, your doctors, your nurses with the burden of caring for that patient alone. Because you can help them, especially if you're part of that care team. So those are some basic reasons. Now let's move on to the actual portions of the pre-anesthetic assessment. So when I think of like a pre-sedative or pre-anesthesia plan, I usually think of it across in 4 categories. 1, 2, 3, 4. Okay. First one, patient. Seems obvious, but I'll go into some details there. The second one is the personality of the patient. Third one, procedure. Fourth, pain. Something we should all care about. So this is how I kind of split my assessment into 4 different parts. So patient. So an assessment of the patient means multiple different things. Obviously, one of the things that you'd probably want to count in there, a history and a physical exam. Why do those things? Well, if I go do a physical exam on the patient, the first thing I'm going to see when I walk in is I can perform a subjective assessment from far away. I can see what that animal is doing, how it's interacting with its environment, what kind of infusions it's on, how the IV catheter looks in the leg, and maybe get an initial picture into what that animal's personality is like. So that's just going to help keep me safe, and as soon as I walk into the kennel, I'm going to be able to get a lot of information even before I put my hands on the animal. So exam from a distance. Then obviously we get into the details of the history and the details of the physical exam, which are going to give us more specific information. So in terms of the history, I think one of the important things to know is the problem list, any diseases that animal has ever had before. And sometimes they don't have diseases, but it's a good idea just to check. Medications, extremely important. And other problems. So let's say I have an animal that isn't coming in until tomorrow for some type of procedure. I'm going to look through the other episodes that the animal's been admitted to the hospital and see if there was anything abnormal ever noted on their physical exam. Like, do they have a raging heart murmur that I wouldn't be able to tell just by looking at the computer? Are they on medications that might make me want to call up the owner and say, hey, you should maybe stop those before you come in here because that's going to result in XYZ problems? Or are they on medications that might impact what I do? So is the animal on insulin or things like that? So that's also going to impact your plan. You want to know those things before they come in if that's at all possible. And then diseases. Lots of old dogs have arthritis. Lots of dogs and cats over the age of 7 have occult heart diseases that we just can't tell they have until they come in. So just be aware of the animal's history that way. So that's the history part of it. Physical exam. Now, when I talk about physical exam, I'm talking about an anesthesia, pain, sedation level exam. There are some things that I don't routinely do during a physical that should be part of a complete physical elsewhere, but I just want to give you what I do so you can help make anesthesia choices. So the focus of my exam is going to be mostly on heart rate and rhythm, respiratory system, limb conformation, I'll get onto this next, and so-called, could have wrote this in red, so-called red flags. So obviously once the animal comes in, I want to try to listen to the heart and the lungs because these are the things I'm probably going to end up affecting most with my anesthetic plan. And those are the two major systems that I'm caring about when I make an animal fall asleep. So heart rate and rhythm. Is the heart rate appropriate for that size animal and for what the animal is doing? It is not normal for an adult large breed dog to have a heart rate of 160. So if I see an animal with a heart rate of 160, I've already done my subjective exam because I walked into the kennel and saw all of the things it was on, and then I did a physical exam and something is not right with that animal. So that should trigger something in my mind about why that is going wrong. Respiratory system. So most of the time when you listen to lungs on dogs and cats, it's going to be nice and quiet, and I hope that you don't hear anything. But there are going to be some animals that are sitting in a kennel panting. There are going to be some animals that have stridor, so they're going to make a lot of noise when they breathe. And you're going to see a lot of brachycephalic dogs and cats. So just get an idea about what is the animal's breathing pattern. Are they making a lot of noise? Does it seem like it's with a lot of effort? Do they seem like they're struggling? And if you think they are struggling or they're making a lot of noise, just assess it further. Put a pulse ox on those animals. I pulse ox animals all the time before anesthesia, especially if they came out of an oxygen cage. I'll try to pull them out to see what they're doing. Because let's say I have to pull them out to do some stuff to them before anesthesia. I want to know that they're not just going to fall over on me. So you can always check it if you're not sure. Limb conformation. Mostly I do this because a lot of animals, they'll have crooked legs or they'll have legs that have had multiple IV catheter attempts, and it's just a nice idea to kind of like size up the scene and kind of get an idea of what you're looking at. Any other red flags? So other things that I would try to catch on a physical exam. Does this animal have a lot of edema in its limbs? Are the legs really puffy? Does it look like it has a huge bloated belly? And what is that? Is that food? Is that gas? Is that blood? Are the animal's eyes really sunken? So is this animal really dehydrated or does something bad happen to it? Or other things like, are their pupils equal? Is there any obvious bleeding? Things that you might want to take care of before you go further. So that's history and physical exam. The next thing I want to move on to is personality. Pretty simplistic. would say largely patients fall into 3 different kind of categories. They're broad. So some dogs and cats are friendly. They're gonna let you do a physical exam, they're gonna let you place an IV catheter without sedation, and they're gonna let you do all the things you need to do, no problem. That means that it's probably gonna go a little bit quicker, which is nice. You're also gonna meet some dogs and cats that are very aggressive. So some animals will come into the hospital and they won't let us do physical exams, they won't let us place IV catheters, and some of them will not let us touch them at all. So there are some animals that come in here that have really high sympathetic drive, and the only thing we're gonna be able to do to handle those animals is to sedate them before we look at them. So that's also something to consider. And then you also have animals that are either gonna be falling into the category of neurologic or ill. So it is never appropriate to make an assumption about an animal's mental status if they're ill, dehydrated, neurologic. Because once you revive that animal's probably gonna look completely different. So just like I said, when you do your subjective exam and you walk into that animal's recovery box, their kennel, just kind of get an idea of what's going on. Because if it's an adult dog that's laying flat out, that's not normal. If it's a very dehydrated dog that's collapsed, that's also not normal. So just kind of get an idea of what that is going to do for you. Procedure. So unlike doing a physical exam where you have to like dive into the history, the procedure, what I want to find out with the procedure is a couple of different things. Number 1, what are we doing? Number 2, how long is this going to take? And I like to know how long it's going to take because I want to pick appropriate drugs that last an appropriate amount of time. And also, if something is going to take longer than 20-30 minutes, if it's going to take longer than an injection of sedation is going to take, that means maybe I should start anesthetizing the animal instead and plan for that. And that means I'm going to need things like induction drugs, I'm going to need intubation supplies, I'm going to need oxygen, and I'm going to need to monitor it, and I'm going to need to have a person available to do all those things. So I like to know how long it's going to take. Usually greater than 30 minutes is usually some type of GA territory, but obviously that is very animal and person dependent. So what are we doing? How long is it going to take? What is your priority list? So what I mean when I say priority list is what does the doctor or the nurse want to get done and what things are most important. Now, if there's just one procedure in a healthy dog, left-sided TPLO, this is probably not going to be a problem because you're probably going to be able to do that in around 45 minutes. However, if you have a really debilitated animal that is getting multiple surgeries, if we have a disaster go on, I want to know which procedure do you need to finish in order for this animal to get off the table. Because if the animal is so critically ill and you can only pick one thing, I want to know what that is so I know how best to help you and how long to plan for this procedure. So I usually like to find that out when the patient's ill, but if they're healthy getting one thing done, you don't necessarily have to bother with that. So, do I have anything else to say about procedure? Positioning. Now, for most animals, positioning during sedation or general anesthesia is going to be pretty straightforward. If you're doing a belly, they're going to be like this. And the head is going to be next to the anesthesia machine, and the belly is going to be facing towards the surgeon. Or if you're doing a TPLO, they might be on their back at the end of the table, or they might be in lateral. That's not a big deal. But there are some other things you might have to consider for certain procedures that are going to affect the equipment you set up and also the things you're going to need in order to be successful. So if you're doing a TICA, so if you're doing ear surgery, the animal is probably going to be at the end of the table facing away from you. So that's going to mean a couple of things. That means you should plan to get extensions for your breathing systems. You're going to need extensions for your IV fluids. You're going to have to think of ways to assess the animal's comfort level and depth of anesthesia without checking the face, because it's going to be far away from you. So think about those things before you just get the animal in the OR and the surgeon walks in and says, oh, I need the patient the other way around. And then you're like, well, darn, I'm the only person here, and now I need to get all this equipment and leave my patient alone. Problematic. It's mostly head, neck surgeries that do this, but sometimes they're just gonna want something weird, and it's just really nice to know beforehand and ask. So positioning. And I'm gonna erase just a little bit of this so I don't have to crouch down and use the last bit of the board. The last thing that's part of my pre-anesthetic or pre-sedation assessment is a pain assessment. And kind of like with procedure, I want to go through that in a couple different portions. Okay, so when I think about pain in animals, before I treat it, I want to know, where do I anticipate the pain being? So if I'm doing painful surgery for the first time, I want to know what type of pain I'm dealing with and where it is on the body. Because if you're just doing a left-sided TPLO, it's probably just going to have pain in one side. But if you have a polytrauma dog or cat that got mowed down by a train, it's probably going to have chest injury, it's going to have abdominal injury, could have orthopedic injury in both of its legs, it could have a bunch of skin problems, it also could have a weird skull fracture. So you need to think about where the pain is, because if you have generalized pain, that is going to influence your plan, and if you have localized pain, that is also going to influence your plan. So where is the pain? How long has the pain been going on? So one of the interesting things about pain is that if you leave pain uncontrolled for greater than 24 hours, it is going to start changing the brain. It is going to start changing the amount of gray matter that you have in the brain and establishing a chronic pain cycle. And one of the problems with a chronic pain cycle is that that process makes it easier for the brain and the spinal cord to trigger pain signals. So the longer you leave that uncontrolled, the greater and the more sensitive that animal is going to be to future pain stimuli. So it's really important to try to control it in the first opportunity that you have. And also, there are drugs that are really good at controlling short-term pain. There are drugs that are controlling pain for 12 hours, and there are also drugs that can modify pain beyond that period, even after that drug is gone. So that's just going to help you pick drugs and pick what kind of techniques you want to use. Type of pain. So when I say type of pain, I mean a couple different things. And it's really about where in the body this is. Kind of ties into that first principle. Okay, you got 10 minutes here. Okay. So, just like there are different types of drugs, there are different types of pain. So different types of pain depend on the nerve fibers that go to that particular body part. A great example of this is the difference between belly pain and like broken bone pain. So bones have a lot of something called fast pain fibers. So when you break your bone, the very first thing you feel is like a very sharp, distinct, I know right where it is kind of pain. And that's because there's a certain type of fiber there. But if you have like really bad food poisoning, a lot of people describe they feel bloated, they feel like they're being stretched, that they're really distended, and that's because there's C fibers in there. So those fibers just pick up different information, and different drugs go to different parts of the body and work in different ways. For example, a lot of you have probably worked with lidocaine before. It's a local anesthetic. There are not a lot of lidocaine receptors on the tip of bone. So lidocaine, just like given to the body, does not provide a lot of analgesia to bone, which is something really important to consider. So just think about where that pain is. So lidocaine doesn't work very well for bone pain, but there are a ton of sodium channel receptors, lidocaine receptors on the guts. So it's great for that and not great for other things. So just think about that when you're picking those types of protocols. And that ties into the next two. What drugs and why those drugs? So you've done your history, you've done your physical exam, you've established that your patient is on medications or not on medications, and you've done a basic assessment of how the heart and lungs are working. You've gone through the steps of establishing what the animal's personality is like and what that's going to mean for your plan. Can I place catheters without sedation? Does the animal need to be resuscitated before I touch it again? Or is it so aggressive that I can't touch it and I should just sedate it and let it cook while I get my stuff set up? And then you moved on to the procedure, which, hopefully you kind of did up here before you got started, but what are we doing? What do we need to get done? What's our disaster plan? And the last kind of portion of that is the pain, where you're kind of thinking about anticipating pain and also treating it with different options for drugs and drugs that are appropriate for that animal. So that's kind of how I do an assessment. I just kind of start from the top and work my way down to the bottom. And sometimes what I do is not enough. Like I've done something and then it ends up being not good for that patient, or it ends up being a wrong plan. But the great thing is that most of the time you can always add, but you can't take away. So I like to start with the least amount that's going to be effective, and then I kind of ramp up from there. Usually that's a good way to prevent yourself from getting in trouble. I don't know if I have a whole lot of other things to note about this specifically, but what I will say on the topic of sedation and general anesthesia is that if I have an animal that's sedated or anesthetized, I always have at least one IV catheter in them. So I put IV catheters in animals that I sedate, and I do this for a couple of reasons. Number one, if they're a CPR. If they die during sedation for whatever reason, they regurgitate, they laryngospasm, they have an arrhythmia, a train comes through the hospital and mows us all down, I want to have an IV catheter now while the vessels are still plump instead of kind of messing about when it actually happens. Number two, if it's not enough, I just want to give more. Okay, like I don't want to mess around and place an IV catheter then and shoot all the vessels before I blow them up. So I might as well have a way to just say, oh, no problem, doc, I'm just going to give it more drugs and it's going to fall straight asleep. And the other thing is, every patient that I sedate or anesthetize, I do at least some basic monitoring. And that could be an assessment of heart rate and rhythm, could be assessment of just their breathing pattern or their rate, but I put actual monitoring equipment on them. And I think the least thing you can do for patients that are either sedated or anesthetized is do something like a pulse ox, maybe a little bit of a blood pressure cuff, they're just sitting there. And if they're intubated, doing end-tidal CO2 or capnography. Because if you were ever in a situation where that animal did go into cardiac arrest or you did have a problem, it would never hold up well in court to say, no, I wasn't monitoring that animal, or no, I didn't have a look at what was going on or try to treat it. So that's just another way to protect yourself and the patient and say like, no, I covered my bases, there was a problem, I told someone about it, it's not a big deal. Because sometimes problems happen and you can't prevent them, but if you recognize them, you're going to be able to reduce your risk and just have a better time, be more efficient. Okay, we have 5 minutes left. That's pretty much all I have to say about the pre-anesthetic assessment. In 2 weeks over at Overland Park, I'm going to be talking about basic monitoring. So we'll kind of extend some of these principles and we're going to talk about basic monitoring. What's normal, what's not, what we should do when that happens, and like don't assume the burden will all be on you specifically, right? Like we're a team, and that's like why we talk to each other and say like, hey, I found this, I see this problem, let's fix it together.